Teşekkür ederim. Ali Sohbet Bey. Günaydın. Merhaba. So fasten your seat belts. I'm going to go as fast as I can to explain this algorithm. I want to acknowledge my co-author, Dr. Othman Mohammed, from our program. We have no financial disclosures. Now, in developing our Mania algorithm, there were three main goals that we had in selecting sequential treatments. One would be the ability to induce remission of symptoms of the manic episode. But also, second, very important, that the treatment we use for the mania would have as much ability as possible to prevent switch into depression, which so often is the next step after mania. So we want to be thinking about that when we choose our anti-manic agent. And third, safety, minimizing harm from the medications, because usually these are medications that are going to be continued long term. We don't want to have to do switching later and take a chance that the switches that we make won't work. So we want to start and be able to stay with medications that are effective and also reasonably safe for the long term, so that the person can live with side effects of this medication. So if you consider those three goals, that actually considerably narrowed the number of choices for what to give in the early nodes of the algorithm. It may seem like we have a lot of medications that work for mania, but not many that meet these three requirements. Now, what are the challenges in meeting these goals? Well, first of all, the evidence is changing all the time. New medications arrive. Some older ones are not working as well lately and have been dropping down in the algorithm. We're finding new safety risks with some of the older medications, changing the risk-benefit ratio of selecting them. We are under pressure from managed care in the United States to keep our inpatient stays short so that we feel pressured to pile on all kinds of non-evidence-based treatments. And finally, clinical experience may be different from what the evidence seems to say, has been stressed by a number of speakers in the symposium over the last few days. Clinicians are often not doing what the experts think is best based on the evidence. So our method of algorithm development is we review the literature, we look at all other guidelines and algorithms, we look at the very latest studies since those guidelines and algorithms were published to see how they might change things. And then the authors reach a consensus on their interpretation of this literature. But then, very importantly for the development of our algorithms, we submit them to peer-reviewed journals where they undergo blinded peer review. And during that process, changes are made and recommendations made. And that has an important impact to add validation to the reasoning that we come up with initially. This is our website where we're displaying our algorithms. I have brackets on bipolar mania because that one is not yet published. It's under review. I mentioned before that it has gone through one set of reviews. We had comments from our reviewers. We made changes. It's now being reviewed again. I thought it might be done by today, but it isn't. So my comments today on this algorithm have to be understood as not yet validated by that final review process. This Mania algorithm is meant to be used in conjunction with our bipolar depression algorithm, which has already been published. This is the reference for it. It was in 2010. We're in the process of updating it, but you can find our latest version on the web. So, to commence the algorithm, before you attempt to apply this algorithm, you have to consider comorbidity, co-occurring diagnoses, and other conditions. There are many that could change the basic default recommendations of the algorithm. I don't have time to discuss them all. They are on our website. They are in the paper. but there's at least a couple I want to bring to your attention. One is if the acute manic patient is extremely agitated, assaultive, needing some kind of parenteral treatment right away to get them under control. What do we recommend for that? We still prefer lorazepam plus haloperidol, typical dose of 2 milligrams of the haloperidol and 5 of the lorazepam IM. They can be in the same syringe. You can also use lorazepam alone, 2 to 4 milligrams. There was a recent study, 2013, which compared this to 3 other treatments and found it clearly the best, both in efficacy and side effects, compared to using haloperidol plus an anticholinergic or using olanzapine or ziprasidone, which are available in IM. Clearly the best was the lorazepam plus haloperidol. We recommend avoiding chlorpromazine IM. That can cause sudden severe hypotension. In a recent Cochrane review in 2010, the small amount of data involved was reviewed. They pointed out that there are these cases of severe hypotension, something you virtually never see with the other options. So if there are any of you out there that are still excited about using chlorpromazine as an IM, which, by the way, was no better than haloperidol efficacy-wise, but much less safe, I recommend you abandon that particular approach. Another comorbidity or complicating situation is dealing with women of childbearing potential with mania. Valproate is by far the most teratogenic and harm-inducing medication to the fetus in our armamentarium. We absolutely recommend avoiding it. There's a new FDA X rating for it. The Food and Drug Administration in the United States gives ratings for pregnancy risk to different medications. And in May 6th of this year, it awarded their worst rating, absolutely contraindicated for valproate. Carbamazepine is almost as bad. Lithium is better, but Ebstein's abnormality occurs in 1 in 1,000 patients. That's not very many, but it is more than control, so it's a concern. Probably antipsychotics are first line for women of childbearing potential. ECT is acceptable, and you should prescribe as few medications as possible. The more medications you're giving at once to a woman who may become pregnant or is pregnant, the more exposure the fetus has to the potential for harm. So in all cases, you want to use the least medications possible, but definitely in those who, in women who might become pregnant. Okay, so the first step in the algorithm is determining if this person what kind of mania do they have? Is it mixed or non-mixed? That's how we felt it was best to bifurcate patients in terms of there being a different algorithm for treatment if they have a mixed presentation versus non-mixed. Now, mixed is very common. It can be seen in up to 40% of manic patients in different studies. The DSM-4 criteria for mixed used to require that you have full criteria for mania and full criteria for depression to be called mixed. But in DSM-5, we now have 2 kinds of mixed. We have mixed primarily manic and mixed primarily depressed. In the mixed primarily manic, they have to meet criteria for mania, and they must have 3 or more symptoms of depression. Some thought it should have been 2 to show the full spectrum, but 3 was what got the final vote. So in other words, the DSM-5 criteria still may not capture the full spectrum of mixed. As little as 2 symptoms of depression may capture and have the same treatment implications as the 3. And the basic thing you need to know about mixed is that it is less responsive to medication, it takes longer to get better, and the treatment algorithm is different. So here's an overview of the treatment algorithm. You may not be able to see this very well. Let me see if I can point out with the pointer some of the issues. I said that the first thing you do is diagnose it, rule out medical etiologies, and you taper and discontinue any antidepressants that they might be on at that point. Treat any substance abuse and comorbid anxiety disorders as appropriate, not with antidepressants. Note if the patient is a woman of childbearing potential, as I pointed out, and then assess previous treatments for current and past manic episodes to see what clearly worked and what did not work. Then, does the patient have a manic or mixed? If it is mixed, our initial recommendation is a second-generation antipsychotic, of which we prefer quetiapine. I'll say more about that in a minute. High doses may be required for the treatment of mixed cases, meaning 600 or more. Some studies have shown up to 800 are needed for a successful treatment of mixed cases. If that works, you continue that for maintenance. If it has an unsatisfactory response, we recommend adding valproate. That seems to be the next best thing to use for mixed mania. And if that doesn't work, we recommend adding lithium. Lithium has some efficacy for mixed, but not as well as either the atypicals or valproate. But it has some efficacy. It's not ineffective. And interestingly, it has a good effect on suicidal symptoms in mixed patients. It may be helpful for suicidal ideation even when it doesn't actually help the mania. So adding it for that reason still could be justified. So that's your first 3 steps for the mixed. For the non-mixed, our first recommendation is lithium as your mainstream first choice. If the response is unsatisfactory, we recommend adding a second-generation antipsychotic, of which quetiapine is again our first choice for reasons I'm about to explain. Across the algorithm, if they get that extreme emergent agitation, you can use lorazepam plus haloperidol. You can consider ECT at any point in patients resistant to meds or who are having a history of positive response or can't tolerate medication. Now, for a little more explanation. There are a couple of good review articles, one by one of the speakers in this symposium, Dr. Fontelakis, wrote a review last year, which he cited actually in his discussion yesterday on the treatment of mixed mania. And he concluded that the atypicals are the best. Also, more recently, there was a study by Swan that reached the same conclusion. Now, why do we prefer quetiapine? Because although it has just average efficacy in mania compared to the other anti-manic treatments, it's just average in terms of effect size. It is unique among SGAs in also being effective for treating and preventing bipolar depression. And remember, we said that was one of the factors that we take into account in sequencing our algorithm, the ability to prevent that inevitable next depression. The other atypicals do not have that proven ability. Now, notably, though, quetiapine is not FDA approved for mixed, but 3 recent studies were quite positive in mixed patients since the FDA reached its conclusions about mixed. So I think it's quite clear from these 3 studies that quetiapine is quite efficacious in mixed. Now, what other atypicals might you consider to start with for mixed? Well, how about olanzapine? Well, it did have a larger effect size than quetiapine in a meta-analysis by Cipriani in 2011. It had a reduction of 0.43. That's about a 43% drop in the standardized mean difference versus placebo, versus 0.37 for quetiapine. Not a statistically significant, but a numerically better result. However, the result in the mixed patients, there was an analysis by Baker where they took out the mixed patients in the bipolar group in the olanzapine studies, and it turned out that the results were quite poor from olanzapine for the mixed symptoms. Depressive symptoms were not improved at all with olanzapine. And also, in any case, even if that were not true, olanzapine probably should not be considered a first-line treatment for bipolar disorder. Other practice guidelines and algorithms have reached that conclusion. The Texas Medication Algorithm Project, the World Federation of Societies of Biological Psychiatry have declared in their review that olanzapine is not a first-line treatment among the atypicals for mania because of its severe long-term side effects. And again, that was one of the priorities that we had for selecting treatments. Now, how about risperidone for first-line use for these mixed cases? Well, that actually had the best effect size overall among the atypicals in Mania. It was 0.5, a little bit more even than the olanzapine or the quetiapine. But there are no adequate evaluations of risperidone in mixed, no studies in bipolar depression. So again, that's why we didn't prioritize it in our algorithm. Some more options you might be considering at the beginning for your mixed patients. Ziprasidone. Well, interestingly, in a post hoc analysis of the mixed mania results with ziprasidone, unlike olanzapine, it was helpful for some of the suppressive symptoms in mixed patients. But ziprasidone was not effective for bipolar depression in 2 randomized controlled trials. So compared with quetiapine, it looks very inferior on the ability to prevent the next depression. And the same thing can be said for aripiprazole. Similar benefits to ziprasidone in mixed cases, but not effective in bipolar depression in 2 double-blind placebo-controlled studies. Lurasidone, Latuda, available in the United States. I'm not sure if it's available in Turkey. Do you have lurasidone yet? Well, it just came on. It just was approved by the FDA in the United States for bipolar depression, adding to our very small armamentarium of effective drugs for bipolar depression. But it's never been studied in mania, so that's why we don't have it in our anti-manic algorithm. Now, after you've used your atypical for your first-line choice, as I said, our next choice was to add valproate to your second-generation antipsychotic. Because the evidence is that very often in mixed, you are going to need combination treatment. Usually it's going to be an SGA plus a mood stabilizer, and the best evidence from among the mood stabilizers for add-on is with valproate. We prefer to give the SGA a good trial first, though, before adding, if you possibly can tolerate the weight, because we want to give as few medications as possible, and we're very glad if you want to use sedation with benzos to help deal with the acute situation. These drugs take weeks to work fully. You want patients to get better than that, faster than that in an inpatient setting, and you can accomplish that temporarily with a benzodiazepine and avoid adding additional unnecessary manic agents. So that's why, if possible, we prefer 1 drug at a time. Once again, avoid valproate in most women. So, again, while waiting for that SGA to work, keep in mind it takes several weeks or more for improvement, much less remission. Remission rates at 3 weeks with all the anti-manic treatments is about 20%. You cannot expect remission from any of these agents within the time frame of most inpatient hospitalizations. The improvement that you get early on during inpatient stay is usually due to a combination of the second generation starting to work, and more importantly, the effects of the supportive milieu, psychotherapy, and sedatives used in the early days of the admission. That's what gets people better quickly on the inpatient unit, not your anti-manic agent. So use those sedatives liberally, in our opinion, and in the opinion of other noted experts on this subject. And as I said before, when I showed you the flow chart, if there's an inadequate response to your SGA and valproate combination, then we recommend adding lithium. Lithium does work. It's a well-established anti-manic in general, but mixed patients who often have increased suicidality, and it may be good for that, as I said before. So again, this is the algorithm for the first 3 steps of mixed. Now we're going to turn our attention to the non-mixed population. Lithium is first. Why is it first? Because it is the only mood stabilizer effective for all phases of bipolar. Valproate has not demonstrated efficacy for maintenance. It's only minor data suggesting it has any usefulness for depression. The only bipolar medication effective for suicide risk is lithium, and it's the only one with clear neuroprotective effects in bipolar patients. It may increase gray matter volume while everything else is shrinking it, and the disease process itself seems to be shrinking it. Lithium may be enlarging. So lithium is the opposite of a shrink for these patients. It's actually increasing volume of key brain areas. More advantages of lithium. Patients on lithium monotherapy in 2 large community surveys were less likely to need any med changes compared to all other regimens. In other words, if you've got your best chance on a monotherapy if lithium is your monotherapy. If you are on other things that you're attempting to use for monotherapy, you're going to wind up adding things to it. That's what these 2 surveys show. One from Europe, one from the United States. Also, lithium was better than even for psychotic mania than valproate in one study. And key point, lithium is just as good for rapid cyclers. Somehow there is a rumor out there that lithium is not good for rapid cycling. It just ain't so. There have been numerous reviews, including this meta-analysis of 900 patients in different trials, showing lithium is just as good for bipolar, for rapid cycling as anything else. No need to avoid picking it for that reason. Now, you may be thinking, well, why not use a second-generation first line for your non-mixed patients? They are reasonable. We have many SGAs that are FDA approved for first-line use. But, as we have noted earlier, only quetiapine has additional approval and effectiveness for bipolar depression, and it also has evidence of ability to prevent depressions and manias. Only quetiapine has that ability. So quetiapine arguably competes with lithium as a first-line choice, but the quality of the maintenance data in quetiapine is very limited. There's only this one study by Weissler, and it was a flawed study. It had a totally enriched sample. In fact, it was 100% enriched with quetiapine responders. So it may not have been a fair measure. It was compared with lithium or placebo. It equaled lithium as a maintenance treatment, but 100% of the patients were known quetiapine responders. So the fact that lithium was just as good, I think, is much more of an endorsement of lithium than it would be of quetiapine as a maintenance treatment. Now, why not valproate first line? I know a lot of people like to use valproate first line, but the evidence is moving against us on valproate. This forest plot shows the results versus placebo in the Cipriani meta-analysis of, this is a Tamayo meta-analysis, of these different studies versus placebo of valproate. And in the initial study in 1994, valproate was much better than placebo. And it got FDA approval, and all of the drug reps went on the road to tell you about it. The speakers have been speaking about it for a decade or two to convince you that this is a great treatment. But notice the downward movement in difference from placebo. In this study in children and adolescents, it was no different from placebo. And in one more study, not included in this analysis, by Hirschfeld in 2010, there was also absolutely no efficacy versus placebo for valproate. This is a large adult study. Added to this adolescent study, no efficacy. So what's going on with valproate? Cipriani meta-analyzed all 5 of those studies. Here's the effect size for everything added together, even including that first good study. It's way less than everything else. It was as high as 0.5 for risperidone, as I pointed out before. And it's never been found effective for maintenance of mania. It has no approval for that. So that's why we don't think it's a good first-line choice for mania. Its weight gain, by the way, is more than lithium. Why not carbamazepine first line? Well, it is effective. It has a new FDA approval for acute and mixed mania in this new slow-release formulation that we have in the United States. But carbamazepine has a lot of drug interactions. There's only uncontrolled reports on depression, no proven efficacy for maintenance. It's hard to dose with self-induction of metabolism. Hyponatremia, blood dyscrasias are issues with it. So that's why we don't have it first line. Okay, so that's the important early phases of treatment. I can quickly go through the remaining phases. After in your non-mixed mania, your regular mania, after you've tried your first generation and your lithium, and the response is still unsatisfactory, we think the next best thing to do would be to change to a different SGA. We have all of these SGAs that work. So pick another one. We're now less concerned about whether it can prevent depression or have maintenance efficacy. This person has now had 2 medications or 3 medications, and they're still manic. So we're desperate for them to get better right now, and we'll worry about the other things later. So you can do your olanzapine or your risperidone now. That's fine. And same thing for the mixed people. Anything you haven't tried, go right ahead with a different antipsychotic, though we don't see any evidence of a value to having 2 antipsychotics at once. Anyway, after those have failed, if they still happen to be manic, then we have 3 tiers of possibilities. One is trying whatever you haven't tried so far. Risperidone, haloperidol is now in there as an acute antimanic. Olanzapine, carbamazepine, or valproate. As a second tier, we have these 3, aripiprazole, ziprasidone, acenapine. And as a third tier for treatment-resistant cases, clozapine. And if that doesn't work, pick another one from this group. So saying a bit more about that, what if the response to lithium is unsatisfactory? We told you that we preferred quetiapine. It comes the closest to being is similar to lithium in all phase efficacy for bipolar. The dose in mania averages about 600. As noted earlier, olanzapine is again not a first-line choice because of its side effects. Risperidone is our preferred SGA other than quetiapine because of its high efficacy and relative. It has plenty of side effects, but arguably fewer than olanzapine. By the way, how does olanzapine compare with lithium in acute mania? In case you're thinking it's not as good. Have a look at this very interesting study. I love to cite this study from Iran, by the way. In 40 women from Iran in an inpatient unit, placebo-controlled, randomized controlled trial for 3 weeks, assessed with a manic state rating scale. Here's the reduction at 3 weeks from lithium at a mean blood level of 8.8, 20 points on that rating scale. Olanzapine, mean reduction at a dose of 20, 7.6. Does anyone believe this study? I mean, this is hard to believe that this really happened. But it was published in a peer-reviewed journal. Now, it turns out there are 2 other studies of lithium versus olanzapine head-to-head for mania. In one of them, the olanzapine was better than lithium. And in the other, they were exactly the same. So if you add the 3 studies together, they're about the same in 3 weeks. Now, what about haloperidol? Why not that as your first-line anti-manic treatment for your non-mixed patient? Well, it is highly effective. It had the largest effect size of all anti-manics in the Cipriani meta-analysis of 0.56, a little bit higher than the risperidone. But we consider haloperidol unacceptable because in a recent meta-analysis, two of them actually, one not recent, haloperidol had the highest risk of inducing depression and neuroleptic-induced dysphoria after treatment of mania. The highest rate of kicking the patient into depression. That makes it very unsatisfactory as an early treatment. The only use we see of it is for that acute IM usage one-time basis for the very agitated patient at the beginning of treatment, but not as a standard treatment anymore. It also has greater risk of tardive dyskinesia in the bipolar population. Now, what about adding valproate to your lithium or to your SGA? Notice that we didn't mention that in the algorithm for the non-mixed people. Valproate was in the mixed algorithm, but not the non-mixed. And that's because the efficacy appears much weaker than previously assumed. But in
Dr. Osser, we are...
so-called game-changing balance study that evaluated the long-term effect of adding valproate to lithium in the management of bipolar disorder. And that study showed a trivial improvement over lithium alone by adding valproate, but a lot more side effects. There was virtually no improvement, just a tiny improvement from the combination of valproate and lithium. So that's why we don't recommend it early on.
Dr. Osser, we are running out of time.
I'm just about at the end. So this is the final steps I've already mentioned, adding a second SGA, and what to do after that. So in conclusion, the treatment of mania is challenging, though many medications are effective for mania or partly effective for acute episodes. Few benefit all phases of the disorder. Some have severe side effects. We recommend using the most evidence-supported and safest treatments first, but changes in our algorithm are certain. Why should I settle for good self-esteem when with the right medication I could have great self-esteem? That's the hope of our patients when we treat their mania.